Hello, everybody.
Hello there.
Hello. Give everybody another couple minutes, and then we will get rolling. That is the jingle that says it is 12:15. Give everybody another minute or so. And the star of the show is here.
You are so mean to me.
I don't have like a flashing light or something like that. I need something.
You have a red coat on. Wow.
We moved wear red day to today because Fridays are like sacred dress down days. You can't touch that. You can't have 2 days on the same day. So I actually even have, which if I was flexible enough, I would lift my foot to show you, but there's no way in hell I can get myself there. So just have to take my word for it.
I think that's a good idea.
It would involve falling and embarrassment. Up your mute.
Just want to make sure the recording's on for that.
Needless to say, I am not Olympic caliber in flexibility, so that would not go well.
What in the world are you wearing?
It's wear red day today for at least Noises wear red day, so I'm wearing red.
All right. Did you have to go out and buy that, or did you have that?
Oh no, I had it. So this is actually a fun discussion. So about 10 years ago, when I was chief of cardiology at Highland, one of the news crews showed up at Highland unannounced and said they wanted to interview the chief of cardiology for Wear Red Day. And I had on like blue and lots of blue. And so I actually had to borrow one of the neckties off one of my partners, put it on. Everybody made fun of me. It became like this whole thing that I didn't adhere to Wear Red Day. So I swore no one would ever out-red me again. So I actually have a red dress shirt. I have a red leather belt. I have red pants. I have red socks. I have red shoes. So I did not wear all of my red, but that's just, when I go all out, I go all out.
Show us the commitment.
Show us the shoes, Chad. We want to see them.
I already explained that there's
He's
no
refusing.
God's green earth. I'm getting my leg that high. So you just have to take my word for it.
Your camera moves.
Yeah, that's a whole thing. It's like wired into the screen. Like that's going to cause a problem.
All right, time to get going.
No more.
Enough fashion statement.
So welcome back, everybody. Fun times in the world of COVID. So actually several updates for today, some of it extraordinarily late breaking. So we'll get right into it. So on the good news, the COVID incidence rate in Monroe County and the surrounding Finger Lakes region is now equivalent to what it was in mid-October of last year. So we have had this spike and then crash, and a good crash of the COVID rates, and it is still decelerating at a pretty rapid rate. So if you look at the 7-day average number of cases per day, we were at about 256 cases per day. Now that's down from over 1,000 before. So we went from 256 per day average over the last 7 days to 102 in the last 24 hours. And we've been on this steady decelerating course for a couple weeks now, which is great. So we are starting to get back to some level of normalcy, if such a thing exists. Because of that, and we are still one of the areas with one of the higher incidences. If you look across the state, especially as you go eastward, that incidence is falling even a bit more rapidly. But just in the last few moments, Governor Hochul announced that effective Thursday or tomorrow, they are rescinding the order or letting the order expire that requires masking in indoor business settings. So you can opt to mask, but it is not required to. Now, notable is she explicitly called out masking in schools and said that they would readdress that in March, anticipating after the spring break time, because they're not yet ready to lift that. That is obviously going to catch a lot of flack. There are other very blue states even that have opted to rescind their masking order, but it was widely anticipated that that was not going to change. And in fact, it was explicitly called out that it is not changing, likely for the next month at least. The other question about healthcare settings, what about in non-patient care areas? Can we go back to the optional masking, or if you're in small groups? That was not addressed, and probably we're still not there yet, quite honestly. Previously, we had kind of taken the tack that we had to be less than the 5% and ideally less than the 2% incidence rate before we got to that part, if you go back to the summer. And we're still a pretty good ways away from that at the moment. So no mention about healthcare, but certainly in businesses, that will expire tomorrow. Also, just this morning, the state put out the ordering process for ordering pediatric vaccine in the anticipation that there will be FDA and CDC approval forthcoming. So that, I can't remember the exact day, but I think it's Thursday or very shortly, you can begin placing those orders that will not be fulfilled until the final approval by Dr. Walensky is given from CDC, which is anticipated to be imminent at this point. So that is also moving forward right now. The other big conversation of the day is the New York State booster mandate. LHDs will not be doing vax on these young children. I probably should know what LHD stand for, but I'm blocking out at the moment. Health Department?
Local health.
Local health departments. Our health departments yesterday said they will not be doing that. They do the 5 to 11, but they're not going to be doing the young kids. And they're concerned that the pharmacies also will be reluctant to do these younger kids.
Okay.
Monroe County said that as well, Michelle?
No, I don't know about Monroe County. They're not part of my 8 counties. All the other rural counties that are members of us, including Livingston, Wayne, Ontario,
Okay.
Seneca, Steuben, Schuyler, Yates.
Okay. Good to
I don't
know.
know if that's
Good to know. All right. And I just totally lost my train of thought. Wow, that just derailed quickly.
booster mandates. Sorry,
Booster.
Chad.
Booster.
So we are awaiting, so it was mentioned from the governor's own Twitter feed that she would have an update regarding the booster mandate. Now, I have not seen any mention of an update to a booster mandate at this point. Unclear if that was an accident, but it came out from the governor's office, which usually means that that's not accidental. We do know that Hospital Association of New York State and multiple other entities have been lobbying for an extension because of concerns about what this could mean for healthcare delivery. I know that as of a couple weeks ago, that was not necessarily in the likely to happen phase, but it sounds like there may have been a little bit of give. The new commissioner for the Department of Health explicitly had stated that she was willing to, or at least was sympathetic to the fact that this could cause service provision issues. So there is another discussion that I'm aware of Friday morning where we may learn more about where those talks are at, but I am not aware of any decision that has been made today in conjunction with the masking change. That mandate is currently set to go into effect as of February 21st. What is thought to be possible is that the governor may opt to delay the implementation, but far more likely they may be willing to expand the criteria of medical exemption. So both have been listed as possibilities, neither are confirmed. And so we're really just kind of waiting to hear where that may go. So nothing on that as of yet. And I was actually looking right up until the moment that I logged on to see if anything new had come out. So if it does, I will amend my statement. Other than that, I don't think there's a whole lot new as far as therapeutics or other discussions. There has been several news articles I've seen in the last few days that the expenditure on COVID therapeutics has gone down precipitously. I would like to say that that has something to do with the decrease in incidence. I can say from my own experience in the hospital, it really has to do with the fact that most of the currently available therapeutics don't have effect against Omicron, so they've been pulled off the market. So whereas we were spending hundreds of thousands of dollars every month on therapeutic treatments for moderate to severe COVID manifestations that were hospitalized, that no longer is really available. So that has changed that process, especially for the monoclonal antibodies, which were some of the most expensive. Otherwise, there have been a couple of other reports, and in fact, several folks have reached out about the KN95 counterfeiting issues. So that is persistent and continues to be widespread. It is, here as of late, and I'm guessing that that will likely amend as of tomorrow when masking starts to diminish. But a lot of folks have been opting to go towards the KN95, likely because theoretically the filtration is better, but they're generally more comfortable than most of the standard N95s. But the amount of counterfeiting is extraordinarily high, and especially for the ones that you purchase off Amazon from independent retailers. You can almost guarantee, it seems at the moment, that those are probably counterfeit. So just know that that is an ongoing concern. I don't really have a lot more update. There are a ton of websites that give ways to identify the counterfeit entities. I wish I could tell you there's 2 or 3 tried and true, but there's a lot more. I think there's probably 8 or 9 different things that you can look for to see if the N95 you're wearing is counterfeit. I can say from my own standpoint that the ones that I received here at Noise that came through the Livingston County Health Department, came from the state, were in fact counterfeit. So even those that you may receive from a reputable source could potentially be counterfeit as well. So that's another part that has come up. Other than that, I don't believe there's any other conversation. Someone did reach out to me and ask the question that for practices that have sites located in hospital-owned facilities. So my good friend Nick Apostolaris on the call. So Tri-County has an office site that's located within a Noise-owned practice, as does Stony Brook. So are they adherent, or are they required to adhere to the New York State masking mandate, or were they involved under the OSHA mandate? My understanding is that the New York State masking mandate for Article 28, 31, 33 facilities is still the prevailing theme at this moment. So if it is a hospital-owned facility, the masking mandate applies. Otherwise, it's treated as a private business. I will verify that that has not in fact changed because someone felt very sure that that was an OSHA and not a New York State requirement, but I'm pretty sure I'm right about that. And that just came up this morning. So I will make sure that I'm not lying about that and get back to everybody. But I'm pretty sure that that is still accurate, but certainly could change when and if the governor changes the mandate as it currently stands for February 21st. Other than that, I don't think I had any big things, so I will hand it over to LJ and see if I come up with anything.
Thanks, Chad. I have 3 topics, just on masking, on vaccination for the youngest of kids. And then also we have a guest with us today to talk about pediatric MISC and what's happening locally in that space. So just for a moment on masking, Chad already reviewed the governor's statement, which is really key. We've talked about how important it is to get out a coherent and clear message to our community about what is being recommended locally by pediatric health experts, county health departments, et cetera. And that could really help inform individual families about their kids. It could help inform schools as well. And so I just want people to know that there is a written statement actually with sort of bulleted, simplified speaking points and a couple of infographics. It's being developed through Common Ground Health and the Schools Reopening Task Force in partnership with Gulf Children's, Rochester Regional, and the infection prevention experts in the county health departments of health in the region. We are hoping that will be ready for release by the very beginning of next week. And we hope that it'll be something that practices can use, healthcare providers can use both in their communication with families and just in any messaging that they have. And essentially the messaging is pretty straightforward. The goal is to keep children in school. That is really important and a high priority for all of us. That masks work, they work regardless of mandates. And that schools are different. It's a congregate setting in some ways, right? You have so many together in a place. And so there is a reason to have some different approaches with schools, and vaccine rates in children right now are not where they need to be. I really think our community does not appreciate as a whole that our vaccine rates are relatively low. We're better than the national average, but that's not saying a lot right now in kids 5 to 11. We've just hit 40%. And so we've got a ways to go. And then you have all these little ones who haven't even been eligible yet. So some of it is a matter of timing. I think it's really important that people realize that we're not saying we never want to unmask children. That's exactly the opposite of what anybody wants, but we want to be smart and do it in an informed fashion. And so I just encourage you, we're pulling that together as quickly as possible, but in general, the work that Common Ground has done with these infographics, I think has been really helpful with some of the messaging we've needed to get out around a number of things, whether it's vaccines and other stuff. And they really do a nice job making sure that there's some parent caregiver feedback to make sure that it is making sense at the same time. Second, moving on from that is vaccination. So I wondered if Kim Povek wanted to speak for a moment, just sort of, I don't know if Kim can, if it's the right time. I wanted to give you the floor for a second. Go ahead.
Absolutely. Thanks, LJ.
You bet.
Just a brief update. We continue to work with Monroe County on staffing and setting up vaccine clinics, specifically for 5 to 11-year-olds. We also know that there are vaccine clinics opening up for those above the age of 11 for booster appointments. We've been quite busy with the boosters, excuse me. Saturdays at Goodman Street, their location in an old Rite Aid has been open for kids. We've been getting a lot of refugee families, which has been really wonderful. They'll come in and the whole family will get vaccinated together. And we continue to offer vaccines, PEDS vaccination at Edgerton, our center on Sundays. We are in talks with the county to determine what will be happening for 5 and below. Or excuse me, for below 5. And we're just waiting for direction there on where they will land as an entity and how we'll be able to support those efforts either with or without the formalization from the county. So if you have any questions, please, you can chat me or get in touch with LJ and we can certainly put our heads together. Just another huge shout out to Jana, Renee, and Kevin. It is a small but mighty team and we really couldn't do this effort without the team here. So thank you all, and another vaccine update coming soon.
Thank you so much, Kim. And I think the only other thing I would just like to say is, the information that Michelle Foster just shared about the local health departments throughout the Finger Lakes region, leave Monroe County out of that because we are waiting to see what their response and plan will be. But knowing that, and also knowing that many pharmacies may not appropriately, I think, be immunizing the youngest of children, There is a toolkit that Jana has been doing a lovely job pulling together that will allow sort of easy access to all resources and a stepwise process for any practice that is not currently vaccinating. And we will be reaching out to those of you. Some have reached to us asking for help and some information, but we really want to do a check throughout our network and help support practices to be able to do that. This will become part and parcel of what is pediatric care and family medicine care for children. And we want to make sure that our practices are able and ready to do that. So stay tuned. And if you are particularly interested in that information, you haven't reached to us already, please do so. You can contact Gina, Renee, or me. That would be great. And then moving from that, last week, I was fortunate enough to be shared some information from Dr. Lauren Solan about some increasing numbers of children in our hospital at Gossamer Children's with MISC, and Lauren was gracious enough to join us today. So Dr. Lauren Solan is the Division Director for Pediatric Hospital Medicine. And I asked if she could just come in an informal fashion. This isn't a formal presentation, just to update a little bit about what they are seeing. I have a few questions for her as she goes through this. We want to re-up again the outpatient assessment guidance that was released in the past and share that with you all again, and then give you an opportunity to ask Lauren any questions you have. So Lauren, I don't know if you want to lead off with a few statements and then we'll pepper you with questions.
Sounds great. Yes. Hello, everyone. No, happy to field questions. So as LJ set me up for, this conversation, I was thinking also that while the outpatient recommendations for evaluation of these patients hasn't necessarily changed, we did make some somewhat significant revisions to our inpatient management. And so I'm happy to talk through what those differences are so that you're aware of how we are caring for those patients based on the most recent updated guidelines from the American College of Rheumatology as well. So I'll start really briefly with some statements and then yes, please ask more questions. But we have seen about 13 suspected MISC cases since the end of October, with 10 of those being only within the last month. And so prior to that, we had many months where we weren't seeing it and had only had a handful over the preceding months. So it was definitely a steep increase in the number of patients. Of those patients, 4 of them did have some time in the ICU, but had very, fortunately, mild courses, did very well, and were discharged home. And then in terms of some of the basic patient characteristics, the age range we have seen is, typically between 4 and 13 years of age with a median of 8 years, although currently there is a 4-month-old admitted that they're working up for it. So, but that is an outlier, as well as some older teens. And yeah, I have some, I'll just stop there. I can talk about other things, but happy to take questions, LJ.
Lauren, I'll start from questions that have come to me, but I encourage anybody else who wants to unmute to ask a question or wants to put a question in the chat. What are you all seeing in terms of sort of the protective benefit, recognizing that some of the age range of the kids you're describing, those are children who are not eligible for vaccination, but for the kids 5 and older, are you seeing, certainly there's a really interesting and powerful infographic that the CDC has put out that shows like a 91% reduced risk of MISC if you're vaccinated.
Yep.
But I just wonder what you guys are seeing in that space. It's a small number of patients, I recognize.
Yeah, no, it's a great question. We were just reviewing that article and another one that I think was in the New England Journal, as well as we were updating our guidelines. And as far as I am aware, I admittedly didn't go into every single chart, but as far as I'm aware, none of the patients who were admitted with MISC in the recent months had been vaccinated at all, or had perhaps only received the first of their 2-dose series. And so certainly we have not been seeing it in the fully vaccinated population, reflective of that information from the CDC.
And Lauren, one of the other questions had been about the age range, because I think we'd all sort of had in our heads that it's typically sort of that school age group, right? Or the preschool, the 4 to, sort of young adolescent. Do you have any idea if that is being reflected in national trends too, that there are younger children presenting with suspected or being evaluated for MIS-C?
That's a great question. I honestly don't know the answer to that one. Yeah, I'm not sure. We have seen here, the one that I just mentioned that is extraordinarily young. But then we had a couple of older teens, like 16, 17, who presented within the last few weeks too. And whether it was coincidence or a reflection of them being older, they had some like unique presenting symptoms in a somewhat different course than some of the other kids we've seen. But I think we are also seeing more variability in symptoms as well. I know that's not what you asked, but
No, it was actually going to be it's so funny. It was going to be the next question, because I think a lot of people are like, is the symptom presentation the same? Is it still all over the board? Is there something? I think for everyone who's on this call who cares for kids, you want to be thinking about this in the right way all the time, and you want to make sure you're advising families for what to watch for, and you want to make sure you're picking up these cases as they're presenting.
Right, totally. And I don't think my answer is going to be favorably received, because COVID continues to stump us and come with a variety of different sort of symptomatology, whether it's acute COVID or MIS-C. So we have been seeing some newer presenting symptoms. As many of you recall, early on, a lot of it was fever, rash, abdominal pain, as some of the core symptoms that we were seeing most commonly. And while we certainly are still seeing that, we've had other instances, and of course, these are one-off anecdotal cases, but some more neurologic type symptoms. At least two of the kids that I'm aware of presented with concerns for meningitis, which we had not seen in some of our earlier cohorts of kids. Fortunately, the symptoms resolved very quickly with initiation of therapy, but they were pretty significant, neck stiffness, headache, that sort of thing, that then complicated the picture to say, is this meningitis? Is this MIS-C? Trying to avoid that COVID blindness of everything is COVID related, which is very hard to do these days. We also have had kids who seem to have more refractory courses. And again, this is anecdotal, but early on in the pandemic, when we were seeing MIS-C, I rarely, if ever, had to reach out to rheumatology. And having been on service within the last few weeks, two of the cases I saw, we had to involve rheumatology because the children had refractory or more severe symptoms. One went on to develop first degree AV block, which has been reported in the literature, but was new, fortunately resolved within a few days, and then had some very impressively elevated troponins, with no cardiac pathology, which is great, but very unusual sort of constellation of symptoms that took a while to resolve. And sort of related to that too is the timing of presentation. That traditional 4 to 6 week post-COVID infection. We have seen a few kids that have presented earlier, more in that like 2 to 4 week range. And again, trying to parse out what's the relationship to the acute COVID infection, or even knowing the documentation of when the infection might be. With Omicron being so prevalent, it was often hard to know. Kids may have been positive and not realized it too. So kind of muddies the picture a little bit with sorting through that stuff. But certainly being able to assess for the antibodies does help parse that out, especially in the kids that we know haven't been vaccinated yet. So, yeah.
You just covered all of my questions, Lauren. So I'm just wondering, Gina or Renee, I wonder if it's possible to share on the screen that outpatient workup that was released out of GCH a long time ago, that has not had revision, and maybe let Lauren just walk us through that for a minute. And then Lauren, if you wanted to take a moment to talk about the changes you were describing with inpatient management.
Absolutely. So yes, on this, so as LJ said, we have not made adjustments to this since we first published it. And the sort of mirror image of this slide for our inpatient management has also similarly not changed. Just again, sort of trying to highlight what the most common presenting features or things we should be looking for when these patients present. have all, remained the same. And then in terms of trying to assess the likelihood and sort of that stepwise fashion of what labs do you get and how do you sort of elevate the concern or assess for the concern, very similarly, starting with some basic screening labs, and then of course sending the COVID PCR, the serology if able, recognizing that won't come back right away, and then CBC, CMP, CRP, and ESR. And then what you would traditionally do with someone for fever of unknown etiology with UA and urine culture and blood culture, and then if relevant, to obtain imaging at that time, and then sort of depending on what that laboratory evaluation reveals, kind of assessing that, the index of suspicion for something like MISC. So I recognize these are pretty vague, but it is hard to get into the nuances of things when it's such a multifaceted diagnosis that overlaps with a lot of other things.
That's helpful, Lauren. And I think we could stop screen share, and we will make sure that that gets into the email messaging that goes out from AHP. Lauren, any other things about the inpatient management you wanted to share?
I think because you guys will see these patients being discharged on aspirin more regularly, and the couple big components of the update from the American College of Rheumatology was that we should be using aspirin on all patients, and then the addition of anticoagulation, whether it's prophylactic or therapeutic, in another subset of patients with the aspirin. So with few exception, for anybody who has a strong contraindication to aspirin use, most of these children will be discharged home on a course of aspirin, regardless of their echocardiogram findings. So early on, originally, not all of these kids were going home on aspirin, and it was sort of case by case basis. But with the new recommendations, they're really suggesting that everyone gets started on aspirin and continue on that until either the platelets are normalized or they follow up in cardiology and get clearance at about 4 weeks after diagnosis. The anticoagulation part is primarily inpatient. I've been using prophylactic Lovenox in more children than I have ever before because of some of the guidance that the literature suggests, the biggest one being an elevated D-dimer of greater than 5 times the upper limit of normal. Most of these children have very elevated D-dimers. And so even if they don't meet other high-risk criteria, like being critically ill in the ICU or morbid obesity or things like that, we are using more of the prophylactic Lovenox in those cases. But unless they have a thrombus, they will not continue on that post-discharge. So I presume you would see far fewer of those children on that therapy. And then the other big-ish change was just more guidance with some of the escalations of therapy for refractory cases and use of other modalities like anakinra or infliximab or other high-dose steroids. So at that point, we're getting rheumatology involved, and most of the kids that we have taken care of that fall into that category have just had higher dose methylpred for a period of days, sometimes anakinra. But then again, they'll go home on a steroid taper that for continuation, we have a consensus-based sort of agreement on what that taper looks like, which goes about, I got to do some quick math here, about 2-ish weeks that they would go home on that taper. And then certainly, LJ has been sharing some of the amazing work that many of you have been doing with messaging about return to sports and sort of how do you advise in that at that discharge time, what families should be doing and what additional follow-up they should have. So we're trying to incorporate that into some of our discharge planning as well.
Thank you for that, Lauren. Yeah, and just so that the primary care teams know all of that information about assessment in your practices for kids who had moderate or the severe COVID presentation kids are being followed by cardiology before return to play, but for the moderate ones, both Rochester Regional Hospital and Gossanos Children's Hospital are incorporating that into any of their guidance, as Lauren mentioned, their post-discharge guidance at both institutions. So Lauren, if a PCP is seeing a child they're concerned about, they've started the workup, they need help, it's still advisable they contact Pediatric Infectious Disease, I'm assuming, for
Oh,
help
yeah.
in that space. Okay.
Yeah, absolutely. I mean, they've been tremendously instrumental, and we've gotten to establish some very close bonds in caring for many of these children. And they are the best first point of contact for sure. And then, assessment of whether referral to the ED or otherwise would be recommended. But yeah, and, from a hospital medicine group, we're always happy to field questions too. It's probably harder to get a hold of us, unfortunately. But yes, I would say that ID would be the best first outreach.
Okay. I can't thank you enough. It's always a pleasure to work with you, to learn from you. And I'm so glad you're over there with your great team caring for these kids. I'm going to pause for a second and just see if there are any other questions. I didn't see anything going into the chat. So if we've missed something that was a question that any of you have, please don't hesitate to go ahead and unmute or pop something in the chat. And after that nice little pause, I will say, I think we did it. Good job, Lauren. No, thank you so much. Really.
No, thanks for having me.
We appreciate it.
Okay. Take care.
All right, you too. So with that, I'm going to turn it to Renee or back to Chad. Anything else?
Nothing for me.
Two quick things that are kind of fun and exciting that I forgot one, and one just came across, obviously. It's like every 5 minutes there's something else new in the world of COVID. So one thing that has come up is I've heard that patients were starting to request antibody titers to be performed to demonstrate that they still have high levels of circulating antibodies, and in some cases to justify why they do not need boosters. So first and foremost, there is no justification for that at the moment. There is no logic or exclusion criteria for any particular antibody titer level. My initial answer to that question was I was not aware of antibody titers, but lo and behold, there are. And they are not cheap. I suspect they would not likely be covered by insurance. However, not only are there antibody titers, but last evening, I believe it was, there was a UK study that came out that actually showed that for folks who had vaccination-induced immunity, that they had relatively low levels of circulating in antibodies, or in protein antibody, which is the capsid protein of the virus, but they had very high levels of spike protein antibodies. For folks who had infection-induced immunity, they had a more balanced level of capsid and spike protein level antibodies. So that theoretically that could differentiate infection versus vaccine-induced immunity. Nevertheless, in folks, they also had gone on the UK study to show that in folks who were vaccinated and then infected, they also did not develop in-capsid antibodies at the same level as those who were unvaccinated. And the thought was that that actually indicates that the vaccines are actually quite successful because the antibodies prevent the vaccine from shedding its capsid and spreading. So therefore that indicates that it's actually neutralizing the viral particles very quickly. It's all kind of cool, interesting stuff, but just want to put out there that if a patient does show up asking for their nuclear capsid protein antibody test, yep, that is a thing. Nope, it doesn't really matter, but it's fun to talk about. The other thing that just makes for fun and interesting and zombie apocalypse kind of discussion is they just sent an email to New York State. They have started to detect Omicron in the white-tailed deer population. So now even Bambi can give you Omicron, so be careful for all your hunting family and friends. But it also, just to make everybody a little bit more nervous, they brought up that spread of the virus in animal populations could lead to further genetic drift and variation determination. So if that doesn't keep you up at night, nothing will. It's Bambi giving you some horrible zombie apocalypse version of Omicron, but so take that for fun. But it also said that there had been no evidence of transmissibility between animals and humans at this point. So that is the most up-to-date and exciting stuff. And other than that, I have nothing. See a little chat action going on, but Jane is handling that super quickly. Perfect. Anything else for anybody? All right, everybody gets 7 minutes of their life back. We will see you next week. Have a lovely, and hopefully it's even better news next time. See ya.
Thank you. Bye.